The topic is lymphedema. There is obstruction to the flow of the lymph. Lymphatic drainage is a problem. The fluid accumulates in the interstitial. Fluid is rich in proteins, leads to edema and changes in the skin over time. There's development of edema, and the edema initially is pitting, but over time turns to be non-pitting. This happens because of chronic stasis, that leads to fibrosis, and that leads to non-pitting edema. The limbs can be involved unilaterally or bilaterally. Initially, the swelling can be resolved by raising the limb, but over time, the raising of the limb does not help and the swelling doesn't go away. And the limb loses its normal contour, and the shape becomes all swollen. It's like a bark of a tree. The stemmer sign can be present, wherein the toes there is squaring, and the ankle, the dorsum of the ankle, there's a hump developed there. The skin of the limb becomes leathery. It's because of the fibrosis over time, and there are all kinds of infections that can develop, fungal infections or cellulitis. Classification wise, it's classified into primary and secondary forms. Primary forms are due to developmental problems, and the lymph valves don't develop properly, and they can be classified. The primary can be further classified into congenital, the precox, and the tarda. The congenital form is basically pretty much detected early on at the time of the birth. The precox is around the teenage group, and the tarda is around 30 years of age. The more common form is the precox. In congenital forms, it's the most early detection at the time of the birth, or around 2 years of age, and it could be familial, as in Milroy's. The precox is the more common form, and it's in the teenage age group. Females are more commonly affected, so there could be role of estrogen. Usually there is unilateral involvement of the limb, and the tarda form is the much later form. It's basically around the age group of 30 years. It's very uncommon, and the least number of cases are seen in the tarda form. The secondary lymphedema is basically due to causes such as surgery for any issues such as the breast, prostate, or lymphomas, and as in mastectomy, removal of axillary lymph nodes can lead to the upper extremity lymphedema. Most commonly, post-mastectomy, it's seen. Filariasis can be observed in the underdeveloped countries, and trauma to the limb or inflammation as a result of filariasis could also lead to lymphedema, and as mentioned before, surgery can also lead to lymphedema. At the time of surgery, if lymph nodes are removed, that can often lead to lymphedema. There are several reasons for the development of edema, but clinically one can think on the tracks of lymphedema by looking at the cutaneous and subcutaneous fibrosis and the stemmer sign, looking at the condition of the skin as a result of cutaneous and subcutaneous fibrosis really helps, and one can try to think that this is lymphedema and exclude other causes of edema, which commonly we all know are like nephrosis or cirrhosis or or myxedema, or hypalbuminemia, or venous stasis, or congestive heart failure, and others. Several lab tests that can be helpful um, in, figuring out that other causes are not present, such as in doing the liver function test, albumin, urine analysis, thyroid function tests, creatinine, BUN. They can help exclude the other causes of edema. VEGFR3 and FOXC2 gene mutations can be looked into to figure out if Milroy's disease or dystichiasis, lymphedema dystichiasis is present. And lymphscintigraphy, nuclear lymphscintigraphy remains the gold standard, and Doppler ultrasound basically helps to figure out if it's not the venous obstruction that's leading to the edema. CT scans help figure out if there are any malignancy issues, and lymphangiography basically is seldom used, but the nuclear lymphscintigraphy remains the gold standard. Treatment-wise, there's the complex decongestive therapy and things like lymph massage and elevating the leg, and then the leg compression. These are all very helpful, and utilization of stockings, which can provide compression in a graded fashion, are often deployed. And the stockings, they cover the entire area which is edematous, and 40 to 50 mmHg is the most commonly used pressure, and the pressure is applied maximally distally, and as you go proximal, the pressure is gradually reduced. Diuretics are not used, lead to decrease in volume, and for any infections such as in fungal infections, clotrimazole can be used. For cellulitis, proper antibiotics can be used, and for filarial infections, as in Wucheria bancrofti and Brugia malae, utilization of diethyl carbamazine citrate is done to get rid of these infections. Surgery can be used along with CDT, or in scenarios wherein the cosmetic issues and the infections are uncontrollable, and the function is kind of lost. So basically, surgery has a role to play in such scenarios.